For examination of the shoulder, we'll start with inspection, looking from the front. We're looking for any wasting, asymmetry, swelling scars. We're looking specifically at the position of the shoulders, the AC joints. Then we get the person to turn to the side. We're looking for the alignment between the shoulders and the ears, cervical spine, thoracic spine. Get the person to turn to face towards this direction. Now we're looking at from the back. We're looking at again position of the shoulders, specifically the shoulder blades and the scapula. At this point we're going to get the person to do an active range of motion just to see if there's any major issues. Just going to get you, if you don't want to lift your arms above your head, your thumbs up and lower again, looking at the scapular movement. Again we're going to get the arms out from the side. We're going to lift the thumbs to meet on top. Excellent. Next thing we're going to do is we're going to do passive range of motion. This is very important to look for any problems in the glenohumeral joint. We're specifically looking to see if there's any loss of range. First test we look at is we're looking at lateral rotation. We're pulling the arm, keeping the elbow at the side out, and what we see here is this full 90 degrees of passive rotation from the position of scapular plane, which is in an angle going in. Specifically, if that is the glenoid, that is the humeral head, it's angled about 10 to 15 degrees in that direction. So, next thing we will compare is with range of motion with abduction. We identify the inferior and lateral edge of the scapula. We lift the arm into abduction in the scapular plane and we feel the initiation of movement of the scapula, which is at about 90 degrees, 80 to 90 degrees, and that's normal. And lastly, for passive range of motion, we'll look at medial rotation. Bring the arm into the base of the back and we see if we can bring it further into medial rotation. There's no extra movement here. If we're unsure that there's an abnormality, we compare it with the other side. Normally we have 90 degrees of lateral rotation, 90 degrees approximately of abduction, and about 90 degrees of medial rotation. Next we're going to look at resisted tests. First of all, we're going to do resisted adduction, ADD. Hands position, you get the person to pull their arm in from the side. Next, we look at abduction, ABD adduction. Get them to pull their arm out from the side. Again, that initial 10 to 15 degrees of abduction is predominantly supraspinatus. Next of all, can you just turn around, Trish, if you don't mind? Yeah. We're looking at resisted lateral rotation. Keeping the elbow at the side, get the person to pull their arm out to lateral rotation. Then medial rotation, pulling in. And next we look at biceps using Speed's test. Arms at the side, pulling forward. It's very good. And triceps are tested by getting the person to pull down with the elbow bent 90 degrees. Very good. Next we're going to look at some tests for what we would call the subacromial space, or some people would call it the letterbox region. Do you mind turning to face this direction? First of all, we're going to look at resisted scaption. Basically, we have the arm into the open cam position, thumb up in scapular plane, and we do resisted elevation of the arm, pulling up, looking for weakness or pain. Then if that's negative, we go into empty cam, the thumb pointing down, get them to pull up, looking for weakness or pain. Next we will do the drop arm test, where we passively lift the arm up and we let the person pull the arm, let the arm come down. If the arm drops, it is suggestive of a rotator cuff tear, large rotator cuff tear. Next, do you mind turning around to face the camera? We're going to check for impingement, and this is Hawkins-Kennedy. So we're going to bring the arm across 90 degrees of elevation, 90 degrees of cross adduction, and 90 degrees at the elbow. And we're basically going to pull the forearm down, causing the humeral head to hit off the acromion and the coracoacromial arch. We're trying to actually catch the tendon in between and pinch the various structures. Next, what we do what's called the scarf test. Just bring your arm right across your body, and this is again testing the AC joint. Additional tests of the AC joint include palpation and Paxino's test. With Paxino's test, we hold the acromion between the thumb and index finger, stabilising the scapula. Then we hold the distal end of the clavicle and we pull it forward and back, and it creates pain in somebody with AC joint pathology. Next, we are going to look at the load shift test for instability. Trish, do you mind sitting down, facing the camera? Load shift test in sitting. Again, holding the acromion with your index finger and your thumb. Next, you hold the humeral head or humerus proximally. You load in by pushing the humeral head in, and you shift by pushing in the scapular plane. So you load to push the humeral head against the glenoid, and then you create translation across the scapular plane. We can also do this test in lying. Do you mind lying down? In this position, I'm going to hold the arm and make sure it's completely relaxed. Just let me take the arm. Once I realise that the arm is completely relaxed, I basically will load and shift. Okay. Our next test we're looking for instability is the apprehension relocation test. Again, the person is lying on the couch. Can you just come closer to the edge here? To get them close to the edge, using your leg as a lever, holding your hand over the glenohumeral joint so that if anybody is subluxing or dislocating, you can stop the dislocation. You bring the arm into abduction, external rotation, looking for apprehension in the patient's face. Apprehension can be a feeling of as if the shoulder is going to dislocate, and if that happens, all you have to do is push down to prevent further subluxation and relieve the person's symptoms. Again, if they get apprehension and that's relieved by relocation,